Good afternoon. My name is Chandrika, and today I will be presenting the clinical case of LC. So, our little background about our patient, who's going to be known as LC. She's a 32-year-old English archaeologist and a treasure hunter who has spent the last years searching for the lost cave of Jaguar God among the Mayan ruins of the Chichen Itza on Mexico's Yucatan Peninsula. She discovered an iron coffin resembling an Egyptian sarcophagus that entombed a well-preserved body of a Maya warrior queen known as the Lady Snake Lord. Elsie's parents were aristocrats. Her mom died in a plane crash, and her father committed suicide when she was young. She knows very little about her parents' medical history, except for possible rheumatoid arthritis on her mother's side of the family. She attended boarding school and earned a PhD in archaeology from Oxford. She's single, she loves treasure hunting, mountain climbing, and fast motorcycles. Diet-wise, she follows a strict vegan diet, and she has her own personal chef, who makes her meals. She doesn't smoke or drink alcohol. She exercises every day, but she still suffers from insomnia. So about her present illness, she has had a 3-month history of abdominal distension, poor appetite. She's also lost 16 pounds. She experiences nausea very frequently, and she's experiencing worsening epigastric pain. It's getting worse and worse. She's also experiencing a lot of vomiting. She was examined at a remote village clinic, and she was also diagnosed with gastritis over there, and she was prescribed antacids, which didn't provide her any type of relief. So a few days ago, she started developing headaches. She got a cough, diarrhea, fever, night sweats, a rash on her legs, and general malaise. She was flown in her private jet to a major medical center in Texas. Her condition from that point quickly deteriorated, and she developed hypotension and pulmonary edema. She was placed on mechanical ventilation in the intensive care unit. The hospitalist ordered a TPN, total parenteral nutrition, per the dietitian's recommendation, as the dietitian was tired of following him all over the hospital in order to get him to sign the TPN order. So abdominal ultrasounds were performed, and the results included the following. The abdominal ultrasound revealed massively dilated loops of the small bowel, which were non-peristaltic. As in the abdominal x-rays, curvilinear structures were noted and seen to be moving independently and were identified in most of the loops of the small bowel. The CT scan also showed the same tube-like structures through the small bowel, a mass in the distal jejunum, and a wall thickening of the terminum ileum, which was believed to have represented a mechanical small bowel obstruction, SBO for short, secondary to oscaritis with associated bowel ischemia. So this is what was done in the OR. She was brought into the operating theater for exploratory laparotomy, where approximately 100 centimeters of the proximal portion of the jejunum was found to be necrotic. Ascaris's roundworm length ranged from 12 to 38 centimeters in length and from 3 to 7 millimeters in diameter. A palpable Bezoser mass was found in the duodenum, which had the consistency of noodles. A duodenal perforation was also identified. Prior to the excision of the small bowel, the Bezoser mass was milked through the intestinal lumen into the necrotic section. The entire duodenum was removed, measuring 22 centimeters as well as 100 centimeters of the proximal portion of the jejunum. An end-to-end anastomosis was created. So this was her post-operative condition. On post-operative day 4, Elsie recovered bowel function and was extubated shortly after. The dietitian wanted to start enteral feedings as soon as possible and went to find the surgeon with the recommendation of Jejivity 1.5 cal at 45 cc per hour for 24 hours, and provided a 1620 kcal, 68 grams of protein, and 816 cc free fluid. The dietitian also recommended 34 cc of H2O and 24 hours for hydration. The surgeon did not know that the dietitian saw him duck into the custodian's closet and followed him there. He signed her order as long as she promised not to lecture him on the importance of early post-operative feeding following bowel surgery. So she did develop some complications, unfortunately, so this was the treatment for the complications. The LC's lower extremity rash on her legs resolved after treatment with fluconazole. However, she developed purpura and hematuria as well as petechiae. She was diagnosed with DIC, disseminated intravascular coagulation, and treated with heparin. She developed stage 3 pressure area on her coccyx. The dietitian worked with her to increase her protein intake while still honoring her dietary preference to a vegan diet. Elsie also received the following medication during this hospital course, which are listed here. The main thing is the 50,000 IU of D2 weekly for 8 weeks. So this is after her discharge. She was discharged after a month of hospitalization and was scheduled for bowel transplant at the Cleveland Clinic. She attributes the return of her long, luxurious hair, her radiant skin, and the ability to ride a motorcycle to the dietitian's expert medical nutritional therapy. She also regained 10 pounds. Earlier, as noted, she lost 16. So she regained 10 of those, 10 pounds. And her strength increased so that she can return to the mountain climbing and tomb raiding. The dietitian recommended spending less time in tombs and caves and exposing her skin to sunlight. The staff who treated her no longer eat noodles. So here are her anthropometrics. So her height is 175 centimeters, admission weight was 53.6 kg, bed scale. Her BMI was 17.4 kg per M2, and her UBW was 61 kg. So in terms of her diagnosis, the primary diagnosis was the hantavirus pulmonary syndrome, valley fever, small bowel obstruction second to Ascarius. Secondary diagnosis was the profound protein calorie malnutrition. So this is her past medical history. So that included insomnia, ADHD, hyperthyroidism, chronic pain attributed to over-adventuring, specifically back pain, vitamin D deficiency. She has type 1 diabetes, slim insulin pump with control, IQ pancreatitis, acute remote second to traumatic injury, ACL injury from snowboarding, subluxation and rotator cuff tear off the right shoulder from mountain climbing, vitamin B12 deficiency. She also sustained a pelvic fracture, which happened in a high-speed motorcycle chase where she caught the bad guy. The Crohn's disease diagnosed in her early 20s past surgical history, and then she also had a terminal ileal resection, approximately 70 centimeters, secondary to Crohn's disease diagnosis. So this is related to her first primary diagnosis, which is the hantavirus pulmonary syndrome. It's an infectious disease characterized by flu-like symptoms that can progress rapidly to potentially life-threatening breathing problems. They're transmitted to people primarily through the aerolization of viruses and shed in infected rodents' droppings, urine, or saliva. The aerolization occurs when a virus is kicked up into the air, making it easy for you to inhale. For instance, a broom used to clean up mouse droppings in an attic may nudge into tiny air particles of feces containing the hantavirus, which a person can easily breathe in. After one inhales the hantavirus, they reach the lungs and they begin to invade tiny blood vessels known as capillaries, eventually causing them to leak. The lungs then flood with fluid, which can trigger any of the respiratory problems associated with the hantavirus pulmonary syndrome. So this is generally the phases. So they advance through two distinct stages. So in the first stage, the patient may experience fever and chills, headaches, muscle aches, vomiting, diarrhea, or abdominal pain. In the early stages, hantavirus is difficult to distinguish from influenza, pneumonia, or other viral conditions. After 4 to 10 days, more serious signs and symptoms begin, which include a cough that produces secretions, shortness of breath, fluid accumulating within the lungs, low blood pressure, reduced heart efficiency. So this is also one of her primary diagnosis. So that's valley fever, also called the coccidiomycosis. It's an infection caused by a fungus, and it's known to live in the soil in the southwestern United States and parts of Mexico, Central and South America. So given her location, she most likely contracted it in Mexico. Valley fever is not contagious, so you cannot catch it from someone else. The fungus that grows in the ground causes it. When something stirs up in the soil, spores from the fungus fly into the air where people breathe them in. Most people who breathe in the spores don't get sick, but some people usually do. Usually, people who get sick from valley fever will get better on their own within weeks to months, but some people need the antifungal medication. So this is the last of her primary diagnosis. So ascariasis is a common parasitic infection in underdeveloped nations. It is caused by the roundworm, and the name is right there, the Ascariasis lumbricoides, if I'm saying it correctly, which lives in the intestines of its infected hosts and transmits eggs through the feces of its hosts. The most common routes of entry for roundworms include oral ingestion from drinking water in which the parasite's eggs are present, or subcutaneously through bare feet that come in contact with the infected feces. Ascariasis is common in locations where there's poor hand hygiene, poor sanitation, and use of human feces as soil. So the eggs of the parasite, it first hatches in the intestines of its infected host, and the larvae move into the bloodstream, where it establishes residency in lungs. After a process of maturing, the roundworm leaves the lungs and travels into the trachea, where they're expectorated or swallowed into the esophagus. The worms that are ingested travel back into the intestines, where they continue to grow, mate, and produce additional eggs. The cycle continues as eggs as either excreted through the feces or hatch in the intestines and travel to the lungs via the bloodstream. So this is the secondary diagnosis, the small bowel obstruction, we're going to talk a little bit more about the ascariasis, and then we'll go on to the secondary diagnosis. So it's an uninterrupted progression of the parasitic infection that can lead to the small bowel obstruction. As the digestive tract becomes obstructed, the patient begins to experience generalized abdominal pain, nausea, vomiting, and poor appetite. So this is in regards to the secondary diagnosis. PCM is the profound protein calorie malnutrition. It's expressed as severe if the patient has two or more of the following characteristics: either significant muscle wasting, loss of subcutaneous fat, nutritional intake, and weight loss of more than 2% in 1 week, 5% in 1 month, or 7.5% in 3 months. It refers to the nutritional status when the availability of nutrients leads to changes in the composition and function. So nutritional impact, fried and spicy acidic food should be avoided. With abdominal pain, foods to incorporate into your diet to ease your symptoms are high fiber foods, low fat foods such as fish, lean meats, and vegetables, and foods with low acidity including vegetables and beans, non-carbonated drinks, caffeine-free drinks. And you should also incorporate probiotics, because probiotics can help with stomach complications caused by the bacteria called Helicobacter pylori, H. pylori, also known as H. pylori. These bacteria cause an infection in the digestive system, which can lead to gastritis, and some of the probiotics you can incorporate into your diet are yogurt, kombucha, kimchi, and sauerkraut. that can all help deal with your symptoms.